About
Keep going.
pulmonary hypertension in the end-stage renal disease population for this ground round. And for those that don't know, my name is Dr. Reginald Obi. I guess you all know by now. I have no conflict of disclosure. I have to mention that. Unfortunately, this is not so clear here, but I guess by introduction, we're talking about pulmonary hypertension, and the real literature from where we start calling pulmonary hypertension in our modern era really started back in the early 1950s. That was when reports of this disease started. We had confirmatory tests of confirming pressures there. And the reason was because the development of cardiac catheterization as a method of diagnosis and confirming pulmonary hypertension became available then. And so the disease itself was now started, the reports started coming up back in the 50s. And cardiac catheterization became the pivotal diagnostic method for the next 3 decades or more. And echo started coming up after that. So we're talking about a disease that pretty much you have to have a confirmatory diagnosis with a cardiac cath. But in this era, of course, you're going to see the dilemma because now we're doing things more with echo, and you see the conflict with that. So the definition of pulmonary hypertension became was agreed upon actually in the first symposium that was held by WHO in 1973. The WHO organized a symposium on pulmonary hypertension, and this was just because just in the mid-60s to the early 70s there was this breakout of primary pulmonary hypertension from all those people with what you call drug-induced anorexic drugs that brought it more to attention at that time. So they agreed upon that pulmonary hypertension is defined as a pulmonary artery pressure on cardiac catheterization that is greater than 25 millimeter mercury at rest and above 30 millimeter mercury on exercise. And also on the cath, you have to document the pulmonary wedge pressure that's less or equal to 15 millimeter mercury. So this is the definition of pulmonary hypertension, and it is a cardiac catheterization definition. Every other thing is extrapolated now. What we're doing now is extrapolation with the echoes, but it's a cath definition, and that you understand is the dilemma down the road. So now, by extension, this definition was actually done for primary pulmonary hypertension. But now they've extended it to all categories of pulmonary hypertension, and you will see that there's quite a bit of categorization in that field. In research done these days with pulmonary hypertension, most people are using echoes, and they're using anything greater than 35 millimeter mercury as their cutoff for what pulmonary hypertension, what they define pulmonary hypertension as in research. So let's talk about how the history of this disease evolved. I mean, from as far back as when people started talking about some problem in pulmonary circulation that was noticed to be causing also right heart failure. And you'll find out quickly that you really can't dig into it much because so many names have been used for this disease in the literature. I've listed a couple that I found. Ayeza's disease is a Spanish guy who actually describes some pathologic cases that were consistent with pulmonary hypertension that we'll find today. They call this syndrome idiopathic pulmonary hypertension. So many names. I like the cardiac negros or black cardiac disease that was used. I don't know why they call it black, but it was names like that in the literature that was in reference to pulmonary hypertension that makes it hard to know exactly how far back this disease has been around. But from what we can tell and what I found in my reading, this is some kind of trend. So from the 1709, this guy, Verhusen, who's more of a pathologist. These were many pathology guys who were doing autopsies, were finding things that they were describing, So he found some sclerotic plaques and pulmonary arteries, and 1891, Romberg and also found things that they thought had a picture of some pulmonary hypertension, and they were looking at pulmonary sclerosis on necropsies and described some cases, and the list goes on. Ayeza was the guy in 1901. He described patients with some right ventricular hypertrophy and chronic bronchitis, and those were a couple of cases he had that kind of led people to think that those people with right ventricular problems had pulmonary hypertension driving that. And Sanders in 1904 started looking into, he had a series of 7 cases that he also found on autopsy who had some right heart-sided problems and some pulmonary artery segment changes that they found. And these people never tied it up as pulmonary hypertension causing problems. They were just noticing these patterns. Then comes this guy Brenner, and this is Oscar Brenner. He's an Austrian clinical pathologist, who very smart guy, who actually started putting. He actually gave a very concise description, even though he had no pressure measurement and stuff there. But he gave a description, and for what the primary pulmonary hypertension as a sclerosis of pulmonary arteries for no obvious reason, either cardiac or pulmonary, as well as hypertrophy of the right, but not the left side of the heart. And at that time, he also believed that this was not one pathologic entity that was causing this problem, but different conditions that would eventually bring up this picture of things that you see. And also around that time, there was also another clinical pathologist, this Vasquez, was also working on cases, and he was a leading pathologist then who people were sending cases to. And he was also describing problems that nobody was going to call pulmonary hypertension, but they all had all these features that fitted the pattern. Until 1951, when Mr. Drysdale, whom everybody would call as the guy who introduced that word primary pulmonary hypertension as a disease entity in the 1950s. So Drysdale is where many arrows point to eventually as the guy who brought it down modern literature now. So talking about classification of pulmonary hypertension, and you understand because pulmonary hypertension has so many things that would lead to it, different disease entities, and the classification has evolved over the years, and even now there's still more evolution to it. So in 1973, the first classification came out, and only had two things. You either had primary pulmonary hypertension or you had secondary pulmonary hypertension. You know, primary pulmonary hypertension, of course, no explanation. Secondary, it had to be a secondary cause. That was the only thing we had there. Then it took 25 years of research and findings for people to realize that, look, that was just not going to work. So in 1998, they had this meeting in France. So you notice that they like to name their classification by wherever they meet. So in Evian, France, they had a meeting, and the second classification for pulmonary hypertension came out. And there they gave 5 classes. I didn't have it there, but you'll see those breakdowns soon. So 5 classes evolved in 1998, and then 5 years later, in 2003, in Venice, they had some modification to that. And all they did pretty much in the Venice classification in 2003 was they removed the word idiopathic pulmonary artery hypertension. They abandoned that term in that classification, but not much change to it. Until 2008, when they had another meeting in California. This is the Dana Point classification. And that's the current classification of pulmonary hypertension that's being used now. And I'll show you what it looks like. Oh, this is not coming out well here, but oh boy. This is all right. Well, they had 5 classes, and I can see on my screen here, but until 2008, and that was why I put, unfortunately you can't see my box right there well, but in this category number 5 is where you see pulmonary hypertension with unclear multifocal mechanisms. And if you go all the way to the bottom, the last sentence there, or last word there, was chronic renal failure on dialysis. That was added in 2008, and it tells you how recent this problem among dialysis patients is actually making it into the classification, because nobody was working on this, nobody was putting out anything on it, and truly the first group of people that started throwing out papers on this, and every other literature coming out on pulmonary hypertension in end-stage renal disease, pretty much coming out from Israel and probably Turkey and the Middle East. Those are the two, and maybe Egypt, but Israel is the big place, and you'll see what we're talking about. So in general, like you see, there's a big classification. Unfortunately, that slide did not show, my earlier slide did not show you all the things in the group for pulmonary hypertension, but there's so many things that will do it, and it's hard to pick out a general mechanism for this disease process. But some things have been observed, and mainly in relation to primary pulmonary hypertension, but there's a lot of generalization as to this being part of mechanisms driving pulmonary hypertension in general. So there were main vascular changes that have been reported in pulmonary hypertension: vasoconstrictive changes, smooth muscle cell and endothelial cell proliferation, and also some thrombosis. Now, the imbalances in normal relationship between vasodilators and vasoconstrictors, as well as growth inhibitors and mitogenic factors, and antithrombotic and prothrombotic determinants have led to most of these changes. And so anything that can affect those balances of what normally exists probably will result in pulmonary hypertension. And these hemostatic imbalances are probably a consequence of pulmonary endothelial cell dysfunction or injury. And some of the things that have been thrown out as causes of vascular imbalances is listed here. So some of the operating chemicals and hormones, prostacyclin and thromboxane A1 affect the pulmonary vasculature, and the balance is for you to, you want them balanced out. But in pulmonary hypertension, you find out that you have less prostacyclin, which is the vasodilator, as well in relation to thromboxane, which is increased. And some studies have shown this happening in primary pulmonary hypertension, where you have breakdown products in the urine of thromboxane being higher than what you see in prostacyclin. So there's a suggestion that there's an imbalance in those two components. Also, endothelin 1 is a potent vasoconstrictor. It pretty much works in the lungs, and it's increased in pulmonary hypertension. And you find, and studies have shown that you find higher levels also of this endothelin in pulmonary hypertension. Nitric oxide is a very big vasodilator that we have in produced by the endothelial membrane, endothelial cells, and it does a lot of things. Vasodilation, inhibits platelet activation, and also relaxes smooth muscle. It's decreased in pulmonary hypertension. Also, notice serotonins, and serotonins play a role. Usually, they promote vasoconstriction also, and also smooth muscle hypertrophy and hyperplasia. And also, we found that they're increased in the conditions in pulmonary vasculature when you examine them in pulmonary hypertension. Another thing that's been mentioned is this thing called adrenomedulin, which is produced in so many organs. Normally, they name them by the first place where they recognize its presence, but it also abounds in the lungs. But now they're looking into adrenomedulin and thinking that it's actually a marker of pulmonary hypertension as opposed to a cause of pulmonary hypertension. That's what recent studies are beginning to show. People are thinking about it. Then VIP, vasoactive intestinal peptide, is also another potent systemic vasodilator, which is decreased in pulmonary hypertension. So there's so many mediators that have been looked at, and you also have this vascular endothelial growth factor found to cause, of course, increased vasoconstriction, as well as smooth muscle mitogenic increase in pulmonary hypertension. Interesting to know there are other growth factors that are being looked at. Fibroblast, FGF, is also in the picture. I don't know about FGF23, but I think it's number 2 and 3 they're looking at. But FGF is becoming also an area they're looking at. So many growth factors are now getting studied more. More science is coming out, and then being implicated in pulmonary hypertension. So the list of things is ever expanding. That's all I have to tell you. Just stay tuned. More stuff are coming out on the molecular level now. And just in a general picture of what we know from what happens with pulmonary hypertension, Harrison put out this table where you see some of the things that are increased and how they affect. So in vasoconstriction, you have a thromboxane A2 is higher, PGI1, your prostacyclin is low, nitrous oxide is decreased, and the list goes on of how these changes affect cell proliferation and thrombosis in pulmonary hypertension. So coming down to our niche of patients, our hemodialysis patient or dialysis-related patient, pulmonary hypertension has actually been found in 40 to 50% incidence. Actually, they're throwing out that incidence rate among patients who dialyze with AV access. And that's the key operational word there, AV access. Because as you will see when I talk about it, AV access or AV fistula or graft access is actually being looked at as a key role player in the cause of our pulmonary hypertension in our population. There's an associated increase in morbidity and mortality, and people have thrown out numbers of up to 30% in 3 years of of mortality from just having pulmonary hypertension and being a dialysis patient. So a lot of derangement in the hormonal and metabolic profile in end-stage renal disease can lead to the pulmonary endothelial dysfunction, and this can result in a restricted ability of the pulmonary vasculature to handle AV access mediated elevations in cardiac output. Now, this third statement is what I'm going to try to kind of show you what people are thinking about as the cause of pulmonary hypertension in our population of patients. So, talking about those who've been working on this, you're not seeing that name very well. This guy, Mr. Mordecai Yelga, if you can see his name, he's the guru of this field. He's a pulmonologist in Israel who's pretty much treating the textbook on pulmonary hypertension in end-stage renal disease patients. Him and his clique of friends who they work in that field have put out so much papers on this topic and actually got that classification, I guess, in the Dana Point thing back in 2008. So he put out this suggested algorithm of what he thought happened with pulmonary hypertension. So you have end-stage renal disease, which is already a problem in itself, leading to pulmonary vascular constriction from uremia and so many other things which we'll talk about. And then this would lead down to people having pulmonary hypertension. And on the right of the screen there, you have people with AV access with the increased cardiac output from that. That would play a role in worsening. Sorry, my pointer is not working well. That will play a role. Pointer is there. That will play a role in worsening. Okay, here we go. Worsening new pulmonary hypertension or worsening existing pulmonary hypertension, and all this will continue to worsen down the road. And then you have this guy, hemodialysis. Oh boy. There's also studied that hemodialysis can worsen pulmonary hypertension, even though we think we help them, but there are things coming out now that we actually could do it, and we'll talk about it. So these are the things that I could find from looking at the bunch of stuff or what people have been touting as possible derangements causing pulmonary hypertension. We have pulmonary calcifications, which you know our population have a lot of calcification. And people have looked into pulmonary calcification and also elevated parathyroid hormone playing a role with the calcification. Also, just endothelial dysfunction from uremia. And one of the better ways to know how uremia, because we can't measure all the uremic toxins. You don't know which one is really playing all the role. But one of the ways to know is by indirect relationship with what happens with transplant. So when you do transplant, people have observed that people with pulmonary hypertension tend to get better, or their numbers improve after a transplant. So we think uremia definitely is there, but what in uremic toxin is doing it, well, who knows? But we're looking at so many things. Increased pulmonary blood flow state rates, states, where you have your fistula or your gap, but mainly fistula is what they've looked at, causing increased cardiac output, as well as some of the things that go with anemia and fluid overload and all that stuff, always potentiating your increased flow and high output cardiac failure state. And then hemodialysis. Now this, I don't know, I read about this thing, microbubbles, for the first time in this, my read up. And that's becoming something people are talking about, and now we'll talk about it. Microbubbles in hemodialysis, what they're doing to our folks. Also duration on hemodialysis and pulmonary hypertension, what's happening with that. As well as access thrombectomies. A lot of talk on that. So let's start with the first one, pulmonary artery calcifications and elevated parathyroid hormone. What we know is that you can, calcification is very difficult to detect. Even if you shoot an X-ray, you might not see people with pulmonary calcification. But from using autopsy studies, they know that at least 60 to 80% of our patients would have calcifications when you check the autopsies. There's a lot of pulmonary calcifications in those folks. Parathyroid hormone, and of course, plays a role with calcification, and they think that's obviously enhancing the calcifications in the pulmonary system. This guy, Ackman, did a study with dogs, and they looked at dogs and induced chronic renal insufficiency in those dogs, measured their pulmonary pressure, measured their calcifications, and I eventually found out that when you do parathyroidectomy on those animals, on those dogs, their pulmonary artery pressure tended to improve. So with those things, the people were throwing out suggesting that possible calcification in our population was playing a role with the cause of their pulmonary hypertension. So people went back to study and see if that truly is what's happening. And Mordecai Yoga, like I said, is an Israeli guy, and his group actually went to look into this. They used technetium 99 and tried to analyze folks by giving a technetium. Technetium is absorbed, and when you have pulmonary calcification, it will reduce the percentage uptake of technetium. And with that, and that will tell you if you could correlate people who have pulmonary hypertension and see that their technetium also is showing that they're having a lot of calcifications, then you can say for sure pulmonary calcification, yeah, definitely there's a relation. However, when they looked at these people, and their study was, of course, the limitation of group or population is you always have a small sample and to do things with, but they looked at people, breaking them down to 29 people who had normal uptake, and they had 20 people that had elevated uptake of their technetium. And when they went back to correlate who had pulmonary hypertension systolic greater than 35 millimeters of mercury, it did not correlate. In other words, there was disparity. 10 out of 20 people who had systolic hypertension. Actually, let me point that out. This is not so clear. I'm so sorry. The slides are not very visible here. But 10 out of 20%, 10 out of 20 people who had elevated uptake did not have evidence of significant pulmonary hypertension. So by the time they did the analysis, they concluded from this actually that the technetium did not correlate. And in that case, they didn't think that pulmonary calcifications actually was a good correlator of who had pulmonary hypertension. And in their analysis, I wish I could point out this well better, but in their analysis, they felt that this probably was not the case. But you can't say completely that it's not. They were just looking at their small sample and felt that they could not prove that there was an issue with uptake of technetium with that population of people. And if you look at, I tried to mark in red the PTH of those people. They also looked at their parathyroid hormones between those who had normal uptake and those who had elevated uptake. Really, there was no significant difference. So in their mind also, the parathyroid hormone did not really play a role with how much pulmonary hypertension you had. So they couldn't link it. There might be some other uremic toxin, but they were not thinking PTH was a big culprit there. So in their conclusion, they felt that the data they had on this little population did not conclusively tell them that technetium 99, that the pulmonary hypertension was related to pulmonary calcifications because of differences in their uptake, and also that PTH probably did not play a role in this group of people. And they were not the only ones. The other small studies and Turkish people did an evaluation. Most people are in agreement in what they've done, that likely the calcification was not an issue with pulmonary hypertension. But parathyroid hormone is still, the jury is not out there yet. They're leaning towards saying it's not, but some people are thinking that there's a big role of PTH correlating with pulmonary hypertension. Anyway, endothelial dysfunction is the big thing that is kind of the common pathway of injury. The endothelial function is key to preserving your vasculature, and if you have problems with that function of your endothelium of your pulmonary vessel, you're likely going to have problems that might result in pulmonary hypertension. Now, studies that were done to show that there was some problems with that end-stage renal population with their endothelial function. This guy called Naku and his friends in Turkey did a study, and apologize for this slide, it's not showing so well here on this screen, but what they did was they looked at nitrous oxide as well as endothelin 1. If you remember from my beginning, I said endothelin 1 is a potent vasoconstrictor, whereas nitrous oxide should be the vasodilator. And they were trying to say, okay, let's see what's happened to these two key things in patients with end-stage renal disease. And if we can tell what is happening, if one is higher than the other, then we can see predict what the imbalance is all about. On the top slide there, they were looking at people who had, they had a population of, I think, 29 normal volunteers, and then they had a population of 42 people who had end-stage renal disease that they looked at. So they compared their findings. On the first slide, they looked at their endothelin 1 levels, and from the normal people who are used as a control, that's the first box there, the cross box there, you could see what the level looked like. Now, when you move on to the second box, which is the group of HD patients before they had hemodialysis, all of the HD patients, they did not separate out who had AV access, or sorry, who had pulmonary hypertension or who did not have pulmonary hypertension. All HD patients that they had, which was 59, that second box was what their endothelin 2, endothelin 2 was before, ET1, sorry, what their endothelin 1 was before they had hemodialysis. Then when they had hemodialysis, there was a slight rise of that. But now when they broke it down and looked at who had pulmonary hypertension and what was happening with who had and who did not have, if you look at it, really the endothelin did not really change for those group of people. So these were patients who had pulmonary hypertension before hemodialysis, after hemodialysis. Now if you notice that those who had pulmonary hypertension, they were a little lower in their endothelin table, but still was higher than normal. So it was really higher than normal folks, but then it didn't really change with dialysis. So ET did not change with dialysis. All right, compared to nitrous oxide. What happened to nitrous oxide? Well, these were the folks who were normal, okay? Starting out, this is our dialysis population, all of our dialysis patients. You know, a little less nitrous oxide compared to normal folks. And then when they did dialysis on them, well, okay, they rose. There was this rise. Well, let's see when we break it down to who had pulmonary hypertension and who did not. So here's our control again. And here's the people who did not have pulmonary hypertension. So you're on dialysis, you did not have pulmonary hypertension. Guess what? When you had hemodialysis treatment, they found that there was a significant rise in their nitrous oxide. Probably to adjust for the flow things with return with your AV fistula, you needed to accommodate for that blood flow that was going to happen to your lungs. So they did accommodate. These folks accommodated well. Well, guess what our folks who had pulmonary hypertension did? So they were already lower. If you see, compared to everybody, they started out with a low nitrous oxide level, showing that there was something going on with the production here. And even after they had hemodialysis, there was a jump, but still significantly low. So there was a diminished response, even with the jump after hemodialysis, not as compared to these folks that jumped so high. This one jumped a little. So in their analysis, they felt, well, in view of the vasodilatory properties of nitrous oxide, it is possible that this attenuated basal and hemodialysis-induced nitrous production contributed to an increased pulmonary vascular tone, because you had unopposed endothelin 1 working, and this could lead to production of pulmonary hypertension. So clearly there's some endothelial dysfunction in our folks who had pulmonary hypertension, and nitrous oxide is felt to be a key player there because it's not responding or not coming up as much. Now these were some of the things they gave out as possible cause of why you had diminished nitrous oxide. So you had, they didn't know why in uremia, why you know, but there was some suggestion. The substrate for nitrous oxide was not very much available in these people. So your L-arginine was low. You also had, there was nitrous oxide synthesis. It's found to be low in people with pulmonary hypertension, pretty much all across the board. And also in our population, they thought this was also low. There was also interactions between nitrous oxide and all the radical things, oxygen species radicals that you have even when you do dialysis. So in uremic state, there's a lot of interaction, diminishing the presence of nitrous oxide, things that reduce its presence. And hemodialysis itself, you know, with all the shear stress and microbubbles and all that, will affect endothelial cells and make it hard, you know, reduce production. So there were some things they could blame as to why your nitrous oxide was not available to help out with accommodating for in these patients. Now, like I said, the people who had transplant, this was where they kind of felt this is your surrogate for telling that uremia is affecting your endothelial cells. And this is it. So these are before transplant. What happened? They had these pulmonary pressures that were high up to, if you check the up notes, some of them had up to 50, 55, 60. And right after transplant, some of these people came down, and the range that we're calling normal is 35, thereabout, you know. And people were coming down close to the range of normal. And this has been documented after transplant and patients that they looked at. Same thing here. When they looked at cardiac output, which is one of the indices of what concerning flow and pulmonary hypertension, cardiac output tend to improve after transplant. So They felt that the endothelial picture of being improved after transplant would suggest that uremia was a big player and endothelial dysfunction was a big player in pulmonary hypertension in a hemodialysis patient. Now, let's talk about AV fistula because that's the one that's becoming a big kicker now. So when you place a fistula, of course, you expect that there will be a lot of return to the other side of it. And of course, there's increased cardiac output with fistula. And, but from physiology, these people have looked and felt that, just having increased blood flow return and increased cardiac output, physiologically, with all the capillaries in the lung system, you should be able to accommodate for those jump in cardiac output. However, when you have problems with your endothelial system and that results in all those vasoconstrictions and all the things that happen in our dialysis patient, then you cannot accommodate for the increase that this our fistula is generating. And if you can't accommodate well, in some folks, now not everybody, now some folks who cannot accommodate for it will now result in increased pulmonary pressure. And considering that you have at least a 30% mortality to pulmonary hypertension, I think we need to be looking at our fistulas closely. So these people, what gave them that courage to make that statement? Well, they looked at some of their patients who had a fistula. And this is a case report, or this is one of their studies where they had 12 patients. And what they tried to do going out is to go and get these patients and make sure they had no other explanation for pulmonary hypertension. They rule out all the pulmonary things, collagen vascular problems that can cause it, and cardiac things to the best of their ability that can cause pulmonary hypertension. So they normally do a good representation of patients who you shouldn't expect pulmonary hypertension in this person, period. And there you are. So they had all these people, and you can see what happened. So they went and took 12 patients they had who fit into who they didn't expect another cause for pulmonary hypertension. Looked at this was done in people before they even got on dialysis. So these are not dialysis patients. These are pre-dialysis, got a fistula placed, looked at the fistula, looked at their echo before they got the fistula, looked at the echo right after they got the fistula. And you can see the months back. They went, after the fistula was between 3 to 7 months. They were looking at their echoes after they got the fistula placed. And so this is their pressures. You can see at least some significant jump. This guy went from, some people, modest changes before and after echo, but you can see somebody that went from 33 to 55. And this was within 6 months of just having a fistula placed. This guy's pulmonary pressure went from 33 to 55, and he was not yet on dialysis. Now, some of the numbers jump out there. This person went from this guy went from 25 to 36, which is above 35, so he's now into pulmonary hypertension range. Somebody went from 22 to 43. 5 out of the 12, I believe, was the number that had significant changes. And you can see changes in their pulmonary pressures. Somebody had 36 change, 20, and this was before dialysis was even started. All they got was a fistula. And within 3 to 7 months, this kind of changes were happening. So they were concerned. I mean, and then here's the guys from Turkey. This is Havlu, I think, yeah, Havluku and his group of friends in Turkey put out this study in 2007 where they looked at also vascular access and actually had flow rates here. And you can see our folks with almost 1200 flow rate here, which was significant because it was significant between difference between pulmonary hypertension and those who had no normal systolic pressure. So their flow rate was statistically significant in the study group they looked at. Their duration on, this was, people were, duration of having the access place was key. So the longer the access stayed in place, yeah, you got in trouble. And of course, the duration of end-stage renal disease, showing that the longer you had all this problem, your endothelial injury and uremia played a role. So fistulas begin to gather a lot of attention, at least in this group of, these studies are showing. Now, also suggesting that fistulas play a role was what happened when you go and try to close up your fistula. So when you close up their fistula, this is their pulmonary pressures. They took this to echo lab, people who had significant pulmonary hypertension, and they will temporarily occlude the fistula or put the pressure and hold it up, and then repeat their echoes while they do that and see what happens. And right there, you see, right after they occlude it, there's a drop in their pulmonary pressure. So, and that also was reproduced with their cardiac output. Once you occluded their fistula, the cardiac output dropped off. So there's a correlation that, possible our fistulas are, output is pushing a lot of blood flow to the pulmonary circulation in a population of patients that have uremia and can have problems with their endothelial function that will prevent them from accommodating the large flows that are flowing back on their right side of the heart, and eventually you will lead into some form of pulmonary hypertension. Now dialysis, or our treatment for our group of patients. Can our treatment cause problem? Well, now we're beginning to see that our treatment is not just benign, it can cause a lot of problems too. Micro bubbles is coming up because, you know, dialysis machines have a air filter, air detectors, but none of them is sensitive enough to prevent micro bubbles. Even if you read the filter, the makers, they'll tell you there's micro bubbles that are released that can escape being detected with your air filter. And those bubbles, I guess because we do dialysis chronically, repeatedly, 3 times a week or even more, you begin to wonder what the impact of this will be over time with our patient population. You know, clearly also the length of time since being on dialysis. Well, yeah, the longer you're on dialysis, obviously puts you in trouble because you're exposed to a lot of shear stress, a lot of microbubbles, a lot of things that can affect your endothelial function. And clearly, we have the last thing here with the accesses that we always do thrombectomy on. Do those things cause pulmonary hypertension? Well, here, this picture is not coming out well. I wish we could say, but there's a. If you look closer, you'll see a lot of bubbles in that field. This is our dialysis stuff. That's the thing that is escaping. Some of it getting to our patients. You don't detect them. You can't stop it. And this came to attention. Actually, cardiac surgeons noticed it. When they were doing surgery, bypasses from their CT surgery, they were beginning to find out that there was more problems, like notice people with stroke-like features and some cerebral dysfunction post-cabbage, and we noticed that maybe microbubbles were doing something to their patient. So now they've extrapolated them to our dialysis patient, and we're seeing that those bubbles are not just benign. Middle Eastern guys too are looking into this, and they're putting out papers out there on how not benign this is. In fact, there's a pathophysiology of what microbubbles will do. So they will cause obstruction, can cause tissue ischemia just by lodging in there and chronically doing that. They also can induce inflammation. So you can have neutrophils induced from the lodging of these bubbles, and this can result in destruction of endothelial cells too. And then there are activation of complements, which is the final common pathway of further destructions, and you amplify the destruction more. So these bubbles are not so benign, and considering that we're doing dialysis chronically on these people every time, they eventually could play a role in destroying the endothelial cells, and obviously the consequence of pulmonary hypertension. So their conclusion: chronically recurrent, ongoing microbubble-induced lung injury may explain the high pulmonary morbidity of long-term dialysis patients. And this was a conclusion from just looking through what they've been finding and they're throwing out there. Then we talk of duration of hemodialysis. And these are patients who have a fistula or who are on dialysis, and we're looking at them and watching what happens with them with systolic pulmonary hypertension with dialysis and the fistula, dialysis through fistula. Now, they put out the case. This is Mordecai and his friend. This was in Chest. This was the big paper. If you ever find it, this was the big paper that probably pushed pulmonary hypertension into the classification in Dana Pointing. So they put out this on these 6 patients, and what happened after they've been on dialysis for a couple of months, several months, from 3 to 25 to 52 months. And what happened to their pulmonary artery pressure, mean pulmonary artery pressure, in that period of time. So you see, for those they had data on, this guy went from 26 to 29, not too bad, but this one didn't have beginning, but he was already 40 after 20 months. This went from 32 to 45, this went from 28 to 48, 30, and everybody, there was just this concern that being on dialysis was not just a benign thing, and those flow rates through our fistulas could make it, en masse on our patients, and they were beginning to develop pulmonary hypertension after being on between 3 to 52 months on dialysis. There were significant changes enough in some of these folks' systolic pressure, pulmonary artery pressure. So the conclusion, so they reported significant pulmonary hypertension in 3 to 7 months of having just an AV fistula creation. And also, when you use it within 3 to 52 months, or for those on dialysis with the fistula, within 3 months to 52 months, there was also significant increase in the pulmonary artery pressure. So fistulas were not totally a benign thing. And how about thrombectomies? Well, send all this for thrombectomies. Send the thrombectomy. Yeah, so many procedures. In fact, the U.S. RDS is reporting that thrombectomies and all this stuff, they are increasing. Every year there's an increase of how much people are getting thrombectomies and work on their fistulas, on their access, you know. And yeah, we're releasing small amount of clot each time, you know, there's little clot thrown out each time you're doing some of this stuff. And the problem is how much of this can cause problems down the road. Now, this was the only study that I found that was looking into this, and this was an American study here, I think it was Pennsylvania. This Harper and his group of friends looked at what you find with pulmonary hypertension, and they had a very small sample size that they looked at. In fact, if you look at the problem with this sample size was that when they tried to match the cases, they were looking at people who had access, who were hemodialysis patients, and they were trying to find a control group. So this control group were normal people who were not on dialysis. So no dialysis patient, that's the last line here. But then the second group they wanted to control with were people who were on dialysis but didn't have to have access work on. And unfortunately, most of them were PD patients. So they had more PD compared to, and of course, pulmonary hypertension is not reported much in PD patients because they don't have AV fistula accesses. That's the thinking. So it was not a good comparison starting out, but they did the best they can. And this was what they found. So after they did their assessment with their analysis, they found out that three things were correlating, or they had increased odds ratio of having pulmonary hypertension with three things: age, female race, and prior thrombectomy was giving an odds ratio that suggested that if you were having this done to you, you could end up with pulmonary hypertension. But when they did their statistical analysis, of course, the odds ratio was suggestive, but they did not get a significant statistical analysis, primarily because of population they had, and also because of people they're comparing with. You know, so but this raises our attention to know that possibly this multiple access, oh, put a hero here, everybody gets work done, oh, thrombectomy here. In fact, just last weekend there was somebody in the hospital that had 6 thrombectomies done. The surgeon gave up after the 6th attempt and sent to VR and said, that's good. And think of how much we keep doing this, and each time you do it, you're breaking up clots, lodging in the lungs, and this can result eventually in problems with pulmonary hypertension. So the age, female gender, and prior thrombectomy, you know, they made that correlation, but not statistically significant. But then there was a trend. They found a trend that was seen in patients with higher grade, those who had moderate or severe pulmonary hypertension, having had greater number of thrombectomy procedures done. So the more you get that done, the more likely that you might end up. I'm sorry, these slides are just not projecting the way I wanted to do. But now we look at mortality in pulmonary hypertension. Yeah, the bottom line is what I want to see there. That bottom line there. If you looked at it, the only thing that was statistically significant in this study that was published by Yelga Mordecai in this 2009 Kidney International study about mortality was that was original significant. Pulmonary hypertension was statistically significant as just having it was significant for causing a higher rate of mortality. And in this study, they put out this was where they were quoting the 30% mortality rate in three years. And this is the curve. This is guy without pulmonary hypertension. These are the people who have pulmonary hypertension after, you know, before HD and after. Even if you started with pulmonary hypertension before and after, yours was worse. These two looked matched alike, and so they were similar in what they were doing. But if you didn't have pulmonary hypertension, you probably lived a little longer. Now, we begin to talk about treatment of pulmonary hypertension. I've talked about things that can play a role in our population, being their endothelial dysfunction, which uremia played a big role with, their access flows and AV fistula issues, and also the fact that we have to worry about what we're doing on dialysis to our patients. Also, chronic hemodialysis could be a big player too. Well, this is general literature on what people do with pulmonary hypertension. And some questions that will need to be asked, and I'll tell you my thoughts on them later. Many people who have pulmonary hypertension, this general approach they do with them: anticoagulation, diuretics, oxygen therapy. Some have found the jogging to be very helpful. This is with pulmonary hypertension, which many are extrapolating, using that to treat other forms of pulmonary hypertension with some caveats, and also exercise. And when you now have advanced, there's some advanced therapies after you've done the general thing, of which you know medications that are out there in this, they're pretty much in these 4 classes of meds. So you have the calcium channel prostanoids, your endothelin receptor antagonists, and your phosphodiesterase inhibitors. Those are the 4 classes of medicines that we have out there pretty much that are used medically. This table doesn't show well, but this will tell you how, where these medicines all work and where. I wish this projector were, unfortunately I won't touch on you to see this, but it just shows where these medicines do the operation in the endothelial system. Anyway, coming to how we manage our patients with pulmonary hypertension, and I'm just throwing out my thoughts from what I read. And I'm going to ask some questions on what I read too, because the jury is not out. Not many people are looking at this subject in the Western world, most in the Middle East. So in people with advanced CKD, is there a role with echo, getting serial echoes, or getting them at least once every year in our population with CKD? In fact, Mordecai Yoga in Israel would say if you find pulmonary hypertension in folks who are pre-dialysis and advanced CKD, you should start thinking of an alternate route of renal replacement other than hemodialysis. Because he believes hemodialysis will worsen their situation and increase problems for them. You should think of PD for those people as a given, and probably early referral to transplant. So if somebody's advancing and we know they're advancing and they have pulmonary hypertension, should we be saying that should play a role in who gets referred and not just EGFR? Should pulmonary hypertension play a role on how should we start thinking of who we should send? Then if someone's on hemodialysis, should we not be monitoring echoes? At least monitor echoes every year and see who on dialysis is developing pulmonary hypertension. They in Israel are rather drastic. If they find that you're developing pulmonary hypertension while on dialysis, they've actually referred people for the surgeons to look at their access and actually reduce the size of their fistula if they can prove that there is increased cardiac output with that fistula. They would send them back and say either reduce it or they will push for transplant or PD just because they're seeing pulmonary hypertension. I don't know that we've gotten that drastic here yet, but that's something that people are doing, and we should consider and see if that should play a role in how we care for our patients here. I had some nagging questions, which I put out there because I just reading all this stuff, I just don't know how to put them. So I started saying nagging questions for me. So should pulmonary hypertension play a role in deciding what modality you take for your patients when you decide who gets on dialysis? Should this play a role for you? And that's key if you look at what is coming out now. And as well, should it determine who gets transplanted, whether sooner or never? I found some places have cutoff for transplant with people with some significant pulmonary hypertension. Should that be the case if we know that some people improve when they get a transplant? Should we not have everybody who's with pulmonary hypertension get a transplant? Who knows? Maybe that should play a role in that decision. AV fistula size and flow. Yeah, I know we look at it on our dialysis chart. Oh, yeah, good flow, high flow. Well, yeah, those high flows, are they really good? And, should we not be worried about pulmonary hypertension with those populations? And then, what is the role of right heart catheterization with diagnosis of pulmonary hypertension in our end-stage renal disease population? Should we be getting this done? And is there any benefit to medical treatment? I tell you what, not many centers, in fact, people are not doing right heart cath on the end-stage renal disease population as much. We use echoes, but should we be cutting them? There are some studies out there that say there's disparity between echo and right heart numbers, although most people say they correlate fairly well, but some have shown some disparities. And some of our patients, should we be trying out medicine? Nobody's treating, I don't know how many of you are treating your patients who have pulmonary hypertension with some of the medical therapies that are existing right now. Should we be trying some of those medicines after we find who could respond after a right heart cath? Those are questions that, really I didn't find any literature to tell me what people are thinking and what people are doing. But it's out there. And that's partly why we need to have more research done in these fields, kind of to guide how to manage our end-stage renal disease population who have pulmonary hypertension. So I went back to that tree that Yoga Mordecai made and tried to plug in what I could find, and kind of it's a modified algorithm that I put out there for what I could find of what's happening in pulmonary hypertension. So we have these people, end-stage renal disease. We know that uremia is a big player here. We know that possibly pulmonary artery calcifications could be here, and also PTH, yeah. So those things playing a role can be players with uremic toxins in end-stage renal disease. And they can lead to endothelial dysfunction and vasoconstriction. I use "and" because that's what it results into, but some uremic toxins just do vasoconstriction. And then that would lead to new pulmonary hypertension or worsening pulmonary hypertension, and maybe to further worsening of pulmonary hypertension. Now this guy, on this axis, we talked about the AV fistula, sorry, axis creation. That's what I wrote there. I'm sorry, it's so small you can't see it. But then, you know, that increased cardiac output, which is what he mentioned before. But with the hemodialysis, microbubbles are becoming now known. People are reporting more and more what they do. Of course, duration of dialysis and also thrombectomies playing a role. And all these together obviously play a role in some form or shape or form to worsen pulmonary hypertension. So in summary, trying to put together all that I could find in my reviews, there's a reason why the data point people said that pulmonary hypertension in the end-stage population is multifocal, and the cause is just so many that mostly bordering on endothelial dysfunction. Now, endothelial dysfunction reduces the ability of the pulmonary vasculature to accommodate the AV axis mediated increase in cardiac output. We need to do surveillance for pulmonary hypertension in end-stage population, end-stage renal disease population. And should this play a role in deciding what decisions we make with renal replacement therapy? And of course, we need further research to tell us how to treat this thing in end-stage renal disease population. I don't know if people are treating it, but we need more research to tell us how to go about with treatment of pulmonary hypertension in end-stage renal disease population. I think that's my slide, and I'm done. Thank you. This is where you clap.